Imagine going under the knife to save your sex life, or maybe just to fix a simple bladder leak that's been bothering you for, years.
Right.
And then you wake up and find out that intimacy is now excruciatingly, permanently painful.
Yeah, it's devastating.
Today we are opening up a massive stack of medical literature to investigate this paradox. We're looking into what happens when surgeries that are meant to heal a patient actually end up destroying their quality of life.
And honestly, it is one of the most frustrating and isolating experiences a patient can go through.
Absolutely.
You go in expecting a solution, and you come out with a brand new, highly complex problem that, frankly, a lot of doctors struggle to even diagnose.
And that diagnostic blind spot is exactly why we're doing this deep dive for you today. We are pulling from a really comprehensive stack of sources here.
We really are.
We've got the UK's NICE guidelines, that's the National Institute for Health and Care Excellence, and we're looking at their data on pelvic organ prolapse. We're also pulling clinical insights from plastic surgery centers that specialize in vaginal rejuvenation, some deep medical data on nerve disorders, and research from the Menopause Society.
Which is great because it gives us a true 360-degree view, right? We're covering the functional side of pelvic medicine and the cosmetic side.
Exactly. So the core mission here is to answer a very specific question that patients are out there desperately Googling in the middle of the night. Can surgery actually cause new painful sex?
Yeah.
But before we even get into the mechanics of it, I think we need to set a baseline. If you are listening to this and you or someone you love is experiencing post-surgical pelvic pain, you really need to know this is not in your head.
No, that it cannot be overstated.
Right.
When you look at the clinical data across all these different disciplines, a very clear evidence-based picture emerges.
Right.
The literature even has a specific name for it. It's called de novo dyspareunia.
De novo meaning new.
Yeah. Exactly. New and dyspareunia meaning painful intercourse. And there are distinct, well-documented reasons, structural, neurological, and physiological, why this happens.
So let's get into the why and the how. Starting with the most direct structural cause, which is the intentional alteration of the tissue itself.
Right, the surgery itself.
Yeah, looking through the plastic surgery data regarding cosmetic and functional procedures, two major surgeries just keep popping up as culprits: vaginoplasty and perineoplasty. And looking closely at the anatomy, it seems like the type of pain a patient experiences depends heavily on, which ZIP code of the pelvic floor the surgeon was working in.
I mean, that is a great way to put it because those two procedures target very different real estate.
Okay, break that down for us.
So a vaginoplasty is an internal procedure. The surgeon is working inside the vaginal canal, usually trying to repair the posterior wall and the underlying muscles that might have stretched out or weakened after, say, childbirth.
Got it. And the perineoplasty.
That one is external. It focuses on the perineum, which is the space between the vaginal opening and the anus.
Okay.
And the goal there is usually reconstructing and often tightening the actual opening itself, the introitus.
And the data shows this really clear divide in the complication profiles based on that. Like if a patient is reporting entry pain, a sharp stinging or tearing sensation right at insertion, that almost always points back to an aggressive perineoplasty.
The opening was simply made too narrow.
Right. But if the patient is experiencing deep pain, like a resistance or aching deeper inside the canal, that usually means the vaginoplasty took out too much tissue from the back wall.
Exactly. It reduces the actual depth or internal width of the space.
Yeah.
And the overriding issue in both of those scenarios is just over-tightening.
Yeah.
There's this incredibly delicate balance in pelvic surgery between providing structural support and maintaining functional flexibility.
Thinking about this over-tightening issue, I just keep coming back to this tailoring analogy.
Oh, yeah.
Yeah, imagine you have a tailor taking a pair of pants a little too aggressively. You pick them up, and on the hanger, they look structurally flawless.
Right. They look great.
The seams are perfectly straight, the fabric is taut, but the moment you actually put them on and try to sit down or climb a flight of stairs, the fabric pulls and tears. Because all the natural give, all the elasticity that you need to move has just been stitched right out of them.
That analogy perfectly captures the mechanical failure we see in these surgeries.
Yeah.
Because human tissue, and vaginal tissue in particular, it relies on elasticity to function.
It has to stretch.
Right, it has to accommodate. But when a surgeon cuts into that tissue, they're introducing trauma. And the body's biological response to trauma is to lay down scar tissue.
Also known as fibrosis.
Exactly, fibrosis.
Yeah.
And scar tissue isn't just a slightly thicker version of normal skin. It behaves completely differently.
It does, right. Like normal tissue is woven in a way that allows it to stretch in multiple directions.
Yes. But scar tissue is dense, it's rigid, and it's disorganized. It acts almost like a biological glue.
Wow. Biological glue.
Yeah, so if a surgeon removes tissue to tighten the canal, the body heals that newly tightened area under tension. It bridges the surgical gap with these rigid bands of fibrosis that just completely refuse to yield during intimacy.
So the anatomy might look perfect to the surgeon during a follow-up exam, like the pants on the hanger.
Exactly. But functionally, it's a disaster.
Which, makes total sense of another really concerning statistic in these clinic notes. Patients who go in for a revision surgery are actually at an even higher risk of developing worse pain.
Wait, revision meaning they're asking a doctor to cut them open again to fix the pain from the first surgery.
Yes, exactly. And it backfires.
Well, yeah, because the surgeon is now walking into a compromised environment. The blood supply to that area has already been disrupted by the first surgery.
Right.
You're operating on pre-existing scar tissue. To borrow your analogy, you were trying to stretch out fabric that has already been heavily patched, glued, and frayed.
Oh, that sounds awful.
It is. The body's ability to heal cleanly diminishes with every successive intervention.
Okay, so that covers the elective tightening side of things. But we really have to look at surgeries designed to fix severe, debilitating medical issues, too.
Absolutely.
I'm talking about things like pelvic organ prolapse, where the internal organs are literally dropping out of position, or stress urinary incontinence.
Right, major functional issues.
Yeah, and the UK NICE guidelines dive deep into the treatments for these. Which brings us to what has to be the most infamous topic in modern pelvic medicine: synthetic transvaginal mesh.
Oh, the mesh controversy. I mean, that completely changed the landscape of urogynecology globally.
It really did.
For years, inserting this synthetic mesh was the gold standard. The logic seemed sound, If the patient's own tissue is failing and allowing the bladder or uterus to drop, let's just insert a permanent synthetic hammock to hold everything up.
But the complication data in these sources is just staggering. We are reading about mesh exposure, where the rigid plastic actually slices right through the delicate vaginal wall.
Yeah, or erosion, where it migrates and embeds itself into surrounding organs, like the bladder.
Good grief.
And even when it doesn't erode, the body recognizes this synthetic material as a foreign invader. So it launches this massive inflammatory response, wrapping the mesh in dense scar tissue.
Which essentially locks the entire pelvic floor into a rigid, agonizing state.
Precisely.
There is a qualitative study in the NICE guidelines from 2020 by a researcher named Brown, and it focuses not just on the clinical data, but on actually interviewing the women living with these mesh complications.
Those interviews are so tough to read.
They really are. The phrases these patients used are haunting. They described feeling powerless in the medical space, inhabiting a body they could no longer trust. But the phrase that really anchors this entire deep dive for me was living in a shrinking world.
A shrinking world. Yeah, it is such a profound way to describe chronic pelvic pain.
Because it doesn't just halt your sex life.
No, the pain makes it impossible to sit in a chair, which means you can't drive to work, you can't go to a restaurant with friends, you can't even sit on the floor to play with your kids.
Your entire perimeter of existence just contracts.
It does. Everything shrinks.
So reading that, the immediate logical reaction is, well, ban the mesh, right? Surgeons should just use the patient's own native tissue to repair the prolapse. If synthetic material causes the body to freak out, biological tissue has to be the obvious answer.
You would think, though. But the sources show native tissue repair historically carried massive risks for de novo dyspareunia, too.
Wait, really? Why?
Largely because of the technique surgeons used for decades. It was called levator myopathy.
Okay, break that down for us. What is a levator myopathy and why was it causing so much pain?
So the levator antemuscles are the core muscular sling of your pelvic floor. In a traditional native tissue repair, if the posterior wall was collapsing, the surgeon would take those deep levator muscles from the sides and aggressively stitch them together right in the middle.
Oh, I see.
The goal was to build a thick biological bridge to block the organs from dropping.
So they are essentially bunching up the pelvic floor muscles to build a dam.
Yes, but the clinical data highlighted a massive anatomical flaw in this approach. By pulling those muscles to the midline, you are drastically pulling the vaginal opening closed.
Yikes.
Yeah. One of the studies noted that this specific technique decreased the size of the opening so much that 33% of the women who underwent it developed painful sex afterward.
33%?
Right. You are fundamentally altering the architecture of the pelvis.
Okay, wait. If synthetic mesh is a dangerous foreign body that erodes, and using the patient's own muscles ends up sewing the opening a third too tight. What is a doctor supposed to actually do?
It's a catch-22.
It really sounds like an impossible catch-22.
It was for a long time. But the complication data forced the surgical field to evolve. Today, the approach has shifted dramatically. First off, surgeons largely abandoned that aggressive muscle bunching technique.
Okay, good.
Instead, they moved to what's called site-specific fascial repairs.
Fascia being the connective tissue.
Yes. Think of fascia as the biological shrink wrap that encases and supports your muscles and organs. Instead of just arbitrarily sewing muscles together, modern surgeons look for the specific tears or defects in that fascial shrink wrap.
Oh, and they just repair those specific tears.
Exactly. It's a much more targeted, anatomical approach that preserves the natural width and flexibility of the canal.
So it's precision repair rather than just pulling everything tight and hoping for the best.
Right. And furthermore, for complex prolapses, there has been a major paradigm shift toward abdominal approaches.
Oh, like not going through the vagina at all.
Exactly, like a minimally invasive sacrocolpopexy. Rather than going in through the vagina and cutting the walls, the surgeon goes in through the abdomen.
Okay.
They pull the prolapsing tissue up and anchor it from above, almost like pulling up a tent by the center pole.
That makes so much sense.
Yeah, and by doing this, they completely avoid cutting into the vaginal canal, drastically reducing the risk of new painful sex.
So the route the surgeon takes to get to the problem is just as critical as the repair itself.
Absolutely.
But, this brings us to the most maddening part of the research. We've established what happens when a surgeon sews tissue too tight, or when mesh destroys the anatomy. But what happens when a patient goes in for their 6-month follow-up, the doctor does an exam, and declares the anatomy perfectly healed. The stitches dissolve, there's no visible tearing, the structure is totally sound, yet the patient is sitting on the exam table in an unbearable amount of pain.
Yeah, this happens a lot.
If the tissue isn't the problem, what is?
That is when we have to stop looking at the structural walls of the house and start looking at the electrical grid. We have to examine the pudendal nerve.
The pudendal nerve, this came up heavily in the data from the advanced reconstruction centers. It sounds like this is the main communication highway for the entire pelvic region.
It is a massive somatic nerve. It exits the spine at the back of the pelvis, weaves its way through the pelvic floor muscles, and branches out to supply sensory and motor function to the genitals, the perineum, and the anal sphincter.
So basically everything.
Yeah, every single sensation of touch, pain, or arousal in that area is routed through the pudendal nerve.
And when this nerve gets damaged, it causes pudendal neuralgia, which is sometimes called Alcock syndrome.
Right.
The sources say surgeries like placing a sling for urinary incontinence or fixing a prolapse or even just the trauma of a vaginal delivery can trigger this. And the symptoms patients report are highly specific and honestly incredibly bizarre.
They are unmistakable once you know what to look for. Patients often describe the sensation of sitting on a golf ball.
Ugh, which sounds agonizing. The data also mentions burning, tingling, electrical shocks, and strangely, pain that gets drastically worse when they sit down, but improves when they stand up or sit on a toilet seat.
Right, because when you sit on a flat surface, you are physically compressing the pelvic floor upward.
Oh, I see.
You're putting direct mechanical pressure on that inflamed nerve. When you stand or you sit on a toilet seat where the center is cut out, the pressure is relieved.
Wow.
Some patients also experience something called persistent genital arousal disorder. It's hyperarousal, but entirely without any sexual desire.
That sounds confusing and terrible.
It is. It's just the nerve constantly firing false, distressing signals to the brain because it is being crushed.
But how does a surgeon accidentally crush this nerve? Like, if they are operating on the bladder to put it in a sling, they aren't anywhere near the main trunk of the pudendal nerve. Does the instrument just slip?
It's rarely a flipped instrument or a direct cut. It is almost always a phenomenon called delayed entrapment.
Delayed, meaning the damage happens long after the patient has left the hospital.
Exactly. So let's say a surgeon places a sling to hold up the urethra and fix incontinence. The surgery goes flawlessly.
Okay.
But over the next few months, as the body heals, it forms that dense scar tissue we talked about earlier around the sling.
The biological glue.
Right. And that rigid fibrosis can slowly spread, tethering the pudendal nerve and pinning it against the heavy, unyielding ligaments in the pelvis. It acts like a slow-moving boa constrictor, gradually suffocating the nerve.
So the patient might feel completely fine for the first 2 months. They go to their checkup, they get marked as a surgical success, and then at month 4, this terrifying electrical pain starts building.
Yes. And because of that time delay, the connection to the original surgery is often completely missed by the doctor.
Oh, of course.
The surgeon says, well, the sling looks great, and your surgery was months ago, so this pain must be unrelated. It leaves the patient feeling like they're just losing their mind.
That is terrifying, but honestly, so validating for anyone listening who has been dismissed because their timeline didn't make immediate sense to their doctor.
Absolutely.
But we can't just blame surgical errors, tight tissue, or entrapped nerves. The physical therapy data and the research from the Menopause Society point out that sometimes the body's own defense mechanisms become the enemy.
Yeah, it's not just the scalpel. It's how the body reacts to the scalpel.
Exactly.
Think about what happens if you accidentally touch a hot stove, or if you pull a muscle in your lower back. Your body flinches, right?
Oh, yeah, definitely.
The muscles spasm and lock up violently to act as a splint. They're pulling you away from the danger and preventing further movement.
Right, like a bad back spasm can leave you completely immobile.
The pelvic floor muscles do the exact same thing when they experience surgical trauma or when a nerve is irritated. They reflexively tighten to guard and protect the healing surgical site.
But the problem is they forget how to let go.
Precisely. This involuntary guarding becomes chronic. It's called a levator spasm.
Wow.
The muscles are locked in a state of high tension 24 hours a day, 7 days a week. And when a muscle is constantly contracted, it restricts its own blood flow.
Just squeezing it out.
Yeah, it builds up lactic acid, just like if you held a heavy weight in your hand for an hour. This creates unrelenting cramp-like pain. So even if the surgeon did a beautiful, flexible repair, your own muscles can clench up and create the exact same impenetrable barrier.
And to make matters even more complicated, we have to talk about the chemical side of this equation. The Menopause Society data makes it very clear that you cannot operate on a pelvis without considering the patient's hormones.
Hormones are a crucial, frequently overlooked piece of the puzzle here. Estrogen is essentially the biological scaffolding for vaginal tissue.
The scaffolding.
Yeah, it is what keeps the tissue plump, elastic, highly vascularized, and well lubricated.
So for a postmenopausal patient or someone who has low estrogen because, say, they've had their ovaries removed or they are on certain breast cancer medications, their tissue is fundamentally different.
It is inherently thinner, drier, and vastly more fragile. When a surgeon performs a structural repair on estrogen-deficient tissue, it doesn't heal as robustly.
That makes sense.
It is highly prone to microtearing and chronic inflammation. So when a patient attempts to have intercourse after a repair, the trauma of the surgery is heavily compounded by the fragility of the tissue itself.
Oh, wow.
Operating on tissue without adequate estrogen is, in many ways, like trying to stitch together wet tissue paper. It just won't hold up to friction or tension.
The picture you're painting here really shifts the perspective. It means that treating post-surgical pain requires a truly holistic view. A doctor cannot just look at the physical stitches.
Right, they can't.
They have to evaluate the patient's hormonal status to see if the tissue is chemically supported. They have to assess the resting tension of the pelvic floor muscles to check for spasms. They have to rule out delayed nerve entrapment. And they have to acknowledge the immense psychological toll of being locked in this pain cycle.
It requires a multidisciplinary approach.
Right.
You really need the structural surgeon, the hormone specialist, the neurologist, and the physical therapist all talking to each other.
We have covered a tremendous amount of ground today, so let's recap the core findings for you listening.
Good idea.
The mission was to answer, can surgery cause new painful sex? The answer is an undeniable, extensively documented yes. The culprits range from the structural-like over-tightening of perineum, dense scar tissue replacing natural elasticity, or synthetic mesh eroding into organs.
Right, and to the neurological, where the pudendal nerve is slowly strangled by delayed scar tissue, trapped against the pelvic ligaments months after the operation.
To the physiological, where the body's own muscles lock into chronic defensive spasms, or where a lack of estrogen leaves the tissue too fragile to recover from the surgical trauma.
And if there is one thing you take away from this synthesis today, it should be empowerment. These complications are real, they are biological, and they are in the literature.
They're not in your head.
No. But more importantly, there are specialized treatments available. We're not just talking about pain management or, learning to live with it.
Right. The sources actually outline clear pathways to relief. There are highly specialized reconstructive surgeons who perform revision surgeries to release tension and remove mesh.
Yes.
There are peripheral nerve surgeons who can go in and decompress an entrapped pudendal nerve. There are pelvic floor physical therapists trained to break the cycle of chronic muscle spasms, and specialized nerve blocks that can temporarily shut off the pain signals to help the body reset.
Exactly.
You have options. You do not have to accept a shrinking world.
But it requires finding a medical team that understands all three pillars: the structure, the nerves, and the hormones.
As we wrap up, I want to leave you with a final thought to mull over. Something that really struck me when looking at the clinical trial and the way these surgical guidelines are written. Think about how the medical system defines a successful surgery.
Yeah, that really exposes a flaw in our medical metrics, doesn't it?
It does. Because if a surgeon performs a procedure and it perfectly fixes a patient's bladder leak or it perfectly secures a prolapsing organ so it doesn't drop anymore, the hospital chart records that as a 100% success.
Right. The anatomical goal of the surgery was achieved. The structure is fixed.
But if that exact same patient is left with debilitating de novo dyspareunia, if they have nerve damage that permanently ruins their intimacy, if they can't sit down at a restaurant without feeling like they're sitting on a golf ball, their overall quality of life has plummeted.
If the structure is physically restored, but the human function and joy are lost, it really challenges the very definition of a cure.
Are we measuring medical success by the wrong metrics? Should success be defined by the anatomical picture or by the reality of the patient's lived experience?
That's the real question.
It's a question that every patient has the right to ask their doctor before they ever agree to go under the knife. Keep questioning those metrics. Keep advocating for the care that looks at the whole picture, not just the stitches. And thank you for taking this deep dive with us today.